And anyone from the crowd can actually also ask your questions from the speakers. Okay, so without further ado, I would like to turn over the mic to our beloved Dr. Mario Ver, our favorite.
Magandang umaga po. Good morning. This early, I would like to congratulate the organizing committee. Though I wasn't here yesterday, I was in the Zoom. I have medical issues, that's why. But today, I'm moderator, I'm here. Okay? So, to the organizing committee, congratulations, really, really nice. Okay? And I would like to, in person, greet Dr. Romel. Belated happy birthday. So, anyway, I hope this will be, again, very interesting format. I think this will be the first time that this is going to be done by PSS. So, an interesting case. Really look at the cases and really interesting. So, but for sake of time, okay, the first case I will be moderating is titled Revision of Wrong Level Surgery in a Chronic Cervical Bilateral Facet Dislocation. This will be presented by Dr. Orland Joshua M. Alimbuyuguen from the Vicente Sotto Memorial Medical Center. Okay, take it away, Dr. Joshua.
Thank you, sir. Good morning, everyone. So I'll be presenting our case at Vicente Sotto Memorial Medical Center titled Revision of Wrong Level Surgery in a Chronic Bilateral Facet Dislocation. I was the previous spine fellow at Vicente Sotto Memorial Medical Center. So I'll try to make this as short as possible. So our case started 5 weeks prior to admission with a 27 male who complained with a chief complaint of lower extremity weakness. Patient was attempting to do a backflip in a Bantayan Island but landed on his head. So just for the sake of location, for geography purposes, Bantayan Island is actually 400 kilometers away from the center of Cebu. So the patient actually went to a local hospital wherein he was advised for radiographs, and the radiographs came out normal as he mentioned, and IFC was just inserted because after 1 day after injury, the patient developed lower extremity weakness as well as bilateral upper extremity weakness. So once the patient already came in to our institution, the patient was already with the following physical exam findings. Patient had no cervical collar on, so with FBC, with stable vital signs, no tenderness on the neck, and no limitation on neck movement. On physical exam, these were the findings. C8 and T1 were 2/5, and then L2 downwards was 0/5. Last normal sensory was T4 with T5, T12 showing 80%, and L1 down was 50%. Patient had upper motor neuron signs, clonus positive for bulbocavernosus reflex, and positive for bladder and bowel incontinence. So these were the radiographs of our patient. So on the AP and lateral, as you can see, there's a break in the usual anterior vertebral body line of the arc, as well as the posterior vertebral body line and the spinolaminar line with around 50% listhesis of C6/C7. These were the patient CT scans with some fusion already, some on the C6/C7, and some perching of the C6 inferior facet over the C7 superior facet, and then what we call the bow tie sign, which is usually characteristic of a bilateral facet dislocation. On the axial cuts of C6 and C7, here you can already see the headphone sign as well as the reverse hamburger sign. And then here you can see on the C7 the superior facet of C7 is already over the inferior facet of the C6 with some interspinous widening of C6, C7. So to note, the patient was already 5 weeks post-injury at this point. So we did an MRI, and MRI showed the following. On sagittal cuts, we don't have any myelomalacia changes on the spinal cord. We do have flattening of the spinal cord against the C6, C7, as noted on this image here. So our diagnosis at this point was an incomplete spinal cord injury, secondary to chronic bilateral facet dislocation, C6, C7, Asia B, AO type C, F0, N3, S-LIX of 9. So what are the numbers with regards to cervical spine injuries? So according to Bowman in his classic article, a third of injuries are usually missed, and according to Reed, 4 to 30% are usually missed due to, most commonly, like in this patient, inadequate radiologic examination. So for our case summary in this case, a 27-year-old male, history of injury more than 5 weeks, complaints of lower extremity weakness, no complaint of tenderness on the nape area, bilateral facet dislocation, C6, C7, and patient already 3 weeks admitted at this point because the patient, upon admission at the ER, also tested positive. So at this point, a patient was already prior to OR, patient was already at 8 weeks post-injury, and no myelomalacia changes on the MRI. So what do we do for this case? Do we observe cases such as this? So when looking at the natural history of cervical trauma, in this new paper by Paula Wengel, so for the natural history without any intervention, cervical traumatic spine injuries, Asia A, some of them convert around 12.5 to 14.6% to an Asia B. Some 8.0 to 9.4% to an Asia C. However, with an intervention, like in this case series that they did, these were a total of 15 studies, there was a noted improvement of up to 2 Asia grades for Asia A patients in complete traumatic cervical spine patients. And the odds ratio for neurologic improvement of early versus late surgery with complete cervical traumatic spinal cord injury was 2.6. So what are the surgical options for cases of neglected or chronic bilateral facet dislocation? So this was a classic paper by Jain. So he presented these several cases, and there was no formal recommendation with regards to what approach or what surgical option that they recommended. However, in the paper by Hassan, in the paper by Basu, so this was the algorithm that they recommended for cases with unilateral or bilateral facet dislocation. But in this case, in this paper, they only had 7 patients with 7 to 21 days for their majority of their cases. So initially they did traction, and if it reduced, they only did an anterior approach. But for patients with an unreduced injuries, they recommended a posterior facetectomy and fusion, or a posterior facetectomy and fusion followed by anterior discectomy and fusion. However, there are also only other recommendations for a ventral reduction approach. So this was a paper recommended by Obewenz, and they had 10 cases of which they only did a ventral reduction approach for their neglected bilateral facet dislocations. So what we did is an ACCF with autologous bone graft. So these were our intra-op. These are our patient position with GA, computer-assisted, with intraoperative neuromonitoring. And these were our intra-op x-rays, of which you can already see our marker at C5, C6. This was our marker at C5, C6. However, as you can note, we can no longer see C6, C7 at this point. These were our intra-op images. And then post-op on physical exam, post-op day 1, the last normal sensory was noted to improve. And then the motors also improved from 2/5. We already have 5/5 on C8, 4/5 on C8 and T1, and then 3/5 on L4, L5, and S1. However, as you can note here on our post-op images, this is the C6, and this is the C7. And we ended up with a plate on the C6, C7, and T2. We did CT scan, and these were our findings. So there was already some fusion on the C6, C7 with our screws, and then ending up on the more superior end plate of C7 with our corpectomy done at T1 and the last screws at T2. So this was the level at T2. So our assessment at this point was incomplete spinal cord injury secondary to chronic bilateral facet dislocation, so C6, C7, Asia B, with autologous bone graft. So wrong level surgery is one of what we call the sentinel events in cervical spine injury. So it's included with a vertebral artery injury as well as esophageal perforation. So it's defined as a surgical procedure that is performed at the correct site, but at the wrong level or part of the operative field. So the prevalence actually of wrong level surgery is 1 of every 2 surgeons in their entire career. And with the decrease in their annual risk of wrong level surgery with the length of practice. Majority of sentinel events actually occur with an anterior cervical plating or anterior cervical fusion. And these were the numbers with regards to the sentinel events as compared to the type of procedure done. So the Joint Commission actually, as well as the American Spine Society, advocate sign, mark, and X-ray, which identify risk factors for possible wrong level surgery. And these are the usual root causes. So they recommended the following: to do a 2-stage approach for spine marking. 1 is marking at the general site, pre-op, verification during timeout, use of marker intra-op, clear lines of communication, surgeon marking the site himself, awareness of congenital anomalies, awareness of risk factors, and use of verification checklists. So we did revision surgery the day after, and these were our intra-op images. So we did a corpectomy of C7 with the plate from C6 to T2. So this was our plate with the longer plate. And these were our post-op X-rays, and these are post-op CT scans. So we did a revision surgery, anterior cervical corpectomy, C7, anterior spinal fusion, C6 to T2 with autologous bone graft. So these were the post-op day 1 of the revision surgery. As you can see, there's already improvement from 5/5, from 3/5 on L4, L5, and S1 to 4/5, both bilaterally, post-op day 1. So this is 4 months post-op for the patient. And then at 5 months post-op. So the patient was actually lost to follow-up because he went back to Bantayan Island, and we can't contact him through, these were images sent to us through Facebook. And then afterwards, I don't know how we lost our account. So initially we were planning to do another CT scan to check for the fusion at C6 to T2. So summary, the role of traction in neglected facet dislocation. There's still a role for traction in neglected facet dislocation cases. There's no definite recommendation as to what type of approach that we should do. We have to be aware of risk factors for possible wrong level surgery, and there are use of checklists to prevent sentinel events. Thank you to the following: the Vicente Sotto spine section staff, headed by Dr. Morales, TO Doc Bellarmino, and the spine fellows and residents who I was with in these cases.
Okay, thank you, Dr.
Thank you, sir.
Alimbuyuguen. We are going to learn a lot from this, but very interesting case.
Yes.
So may I just ask, raise of hands, how many of you have had wrong level surgery? I myself included. So, especially during early days when we don't have C-arm in the operating room. I've had my share, to be honest with you, cervical, because one, not that clear, especially if you're looking at C67, okay, and maybe carelessness, that's number one, okay. But the report was saying that it is more in the cervical.
Yes.
My hands, and I've had committed this, I think it's more in the lumbar.
In the lumbar.
The problem is that we don't report it because, anyway, I just do laminectomy all the way up there. Am I correct in that perception? That there are more lumbar missed level, but you only got to report it because it's not, okay, anyway, I just extend my decompression. Is that correct? Okay. So, Dr. Alimbuyuguen, so there are so many issues. Obviously, one, this is labeled as chronic. You mentioned
Yes, sir. It's
really neglected.
neglected.
3
3 weeks or more, sir.
Okay,
By
that will
Hassan.
be much longer when you're talking because in our situation here, sometimes you cannot operate right away. Because of issues. Okay, so we're bordering very close. Although, of course, this is an emergency that we have to do. Anyway, may I just ask the floor? Any question from? Okay, yes, or JP?
Thank you, sir. Orland, thank you for that presentation, a very well presented case, and I think it's very important for us to look at our mistakes as learning procedures. I'd like to note, maganda yung presentation mo ng yung lit review on how to approach, how to make the decision. But my question is more specific to the case.
Yes, sir.
Which of the factors that you mentioned you think played the role in how come you missed that level? Was it actually that you missed that level, or yung nag-confuse lang kayo, hindi nyo na-extend yung plate, or was it unrecognized at that point?
It was actually unrecognized, sir, because when we reviewed the gross images during that time, the C6 and C7 were already fused together anteriorly. So it was one of our mistakes, I think, because we couldn't, we used the technique of marking, we using the needle, and we counted down from C4, C5 to C6, and we counted downwards, and we didn't find the space in between C6, C7. Yes, we only found the space in between C7, T1.
So, I think the next question is correct to that is how are you going to more or less tell us what is the correct way now? How are you going to learn from this?
In order to get that right, sir, I think because this patient also had a grossly short neck, we could have placed in other journals or in other studies that I found, they placed a cufflinks for the hand, so that just in case when you have a short neck or you can't you can still pull the arms downwards without any difficulties for some patients.
You did not show any AP on your check X-ray.
Yes, sir. Yes, sir. That's it. That's one.
Did you do that?
We did that, sir, but
Still miss it.
yes, sir. We still
Maybe
missed.
it's also not that simple to
Yes.
count, especially if you don't see, because count from at the top, because your position, you did not take a good X-ray, at least angled, then you might not be able to see C1 and then count it properly. Anyway, so Dr. Tanhente?
Yeah. Actually, ikaw ang nag-opera or may consultant ka?
I was with the consultant, sir, of course.
Actually, sino consultancy?
Cebu, yes, sir.
Actually, I'm so impressed impressed in the sense na ang galing, ang question ko kasi is related to the surgical approach.
Yes, sir.
Kasi when you go down to T2,
T2, yes, sir.
you need a supramandibular approach,
Yes, sir.
supraclavicular approach, and then you cut the sternum, right?
Yes, sir.
Make a cut sa sternum. Ito, naabot nyo sa baba eh.
Yes, sir.
So, ang galing nyo.
We were also surprised that we could reach up to T2, sir.
This proves na kaya abutin. So, ang question ko is, what is the surgical approach?
We did anterior approach, but the incision was longitudinal, sir. Yes, sir.
Congratulations. Impressive.
Yeah, you cannot question success. Marami pang question, but as far as the success of the patient, okay, so that's said, wow, great case. I cannot question success. So, but anyway, as to the approach, yes, that's not that easy. But with the use of a microscope, you tilt it. Yes, I have had also experience, surprised too, that you can reach T2. That is, okay. So, any other, yes, question?
Yeah. Well, number one, a good presentation.
Thank you, sir.
Just a comment, no? When I was looking at your presentation, dun sa pre-op x-rays,
Yes, Doc Liz.
I actually forgot that we were talking about wrong level. Pero nung pre-op, if you recall, it wasn't that good. Sometimes, no, I mean, we also have that experience, no? The x-ray is just not that good for some reason that day. So, I mean, it doesn't matter if it takes hours for you to get, but just try to get the best possible x-ray. If you review, if you go back to that pre-op, talagang, it wasn't really the best eh.
Yes.
I was asking myself when you were showing that, tama ba yung ano? I mean, how did he know that it was at the level of this, no? So yun lang, I think it happens to all of us, especially sa lumbar, obese, sa cervical naman,
Short neck, sir.
It happens, but you know, just a comment.
Okay, for the interest of time, I would like to ask the audience here, as far as the fixation, how many of you will recommend augment posterior fixation? This is a corpectomy, okay? Not just one level, but even at one level, just to give you, I am really, because I've experienced it, that the reported, okay, and it is subaxial, not cervicothoracic, which is even more of a problem. That's close to 60% to almost 90% failure rate if you just do a corpectomy more than one level, okay? That is the report, at least 30 to 60%. If it's one level, two level, you know, close to 60 to 90%. So my question, may I ask, are you going to, how many of you will,
After the first surgery or
even the first and more so the second surgery, how many of you will recommend augment posterior fusion? The second surgery. Only one? No. Me, as I said, because I've had worse experiences of failure, and therefore I'm an advocate of you have to augment your anterior fixation by posterior fixation. That's the data. And I tell you, I've had those. I can present to you a lot of, not just my cases I've seen, pseudoarthrosis, maybe symptomatic, kick out, and the likes, okay? So, but only Romel is saying that he will recommend posterior augment fusion. Okay. So, any other question? Yes, this Romel.
we have 2 minutes. It's interesting to note that after the first surgery, the patient improved 2 grades.
Yes,
Is that right? In spite of the wrong level surgery. How can you explain this?
One way to explain this, sir, is we realigned the spinal canal appropriately. So we still even doing the wrong level surgery during the distraction maneuvers, we still increased the spinal canal at that point, but not up to the point that when you can already do a proper corpectomy at C7.
Just a follow-up question. Was the patient placed on a traction even before?
No, prior pre-op, sir. No, sir, because the patient had no limitation of movement and no tenderness at the cervical or neck area. at admission.
Okay, just I also read that if you're talking of neglected, real neglected, it's usually a combined, sometimes three, posterior, anterior, then posterior. But as I said, how can you question success? They were able to do it. So that's why, ano ba yung neglected? Kasi 3 weeks lang. Is that really the definition?
Looking at the journals here with chronic or unilateral and bilateral facet dislocation, there's only one journal that I saw, and he also quoted Vaccaro, which was the original journal. That it was Hassan who actually noted this in the PowerPoint, and he mentioned that at 3 weeks or more, that's already classified as neglected. Or once you already miss it at 3 weeks, it's already classified as neglected.
Okay. Do you have one more question?
Just one last point. Not a question, but actually kudos to the operating team also for recognizing this fast and being able to talk to the patient and do it as soon as possible. So you did it the day after.
Yes. Yes.
So this takes a lot of guts.
Yes.
And it's just kudos to the operating team for being able to pick this up and make the decision.
Very good. Okay.
Thank you, sir.
Okay. It will be different if this is a private patient. I mean, yes, I've been into that situation. I don't deny. I recognize that a level, wow, I didn't, it's a 2 or 3 levels, but I missed one level that is very important. So I just found out and when we took the x-ray and it's a private patient, what are you going to do? So yes, you have to tell, and following day we went back. At least the patient was understanding. That's why I said this happened when you don't have, that was very early on, you only have portable, no C-arm, and still not that good. Okay, so, but as I said, how do you address this if this is a private patient? I don't know. It's very, very complicated, but if you have good rapport with your patient and you tell them possible risks, maybe I was lucky then. Okay, but at least as I said, in your case, you cannot question success, and patient is ambulating. Wow, that's really good. Okay, with that, we don't have time.
Thank you, sir.
So I'll end with the Sotto Memorial.